Hello, and thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. We are delighted to have today's seminar co-sponsored by the University of Minnesota School of Nursing. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions buttons next to the raised hand option in the Zoom menu. The public slide deck will be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. And in particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder for upcoming LHS events, the next seminar will be on May 7th with Dr. Debbie Pesca of the University of Minnesota. And with that, I will turn it over to Dr. Genevieve Milton-Mukes to introduce our speaker.
Thanks, Stephanie. On behalf of the University of Minnesota Center for Learning Health System Sciences and the School of Nursing, we are thrilled to be hosting Dr. Suzanne Bakken as April's Impact Seminar speaker. By a matter of introduction, Dr. Suzanne Bakken is a faculty member at Columbia University, where she serves as the Alumni Professor of Nursing and Professor of Biomedical Informatics. She's a world-renowned informatics researcher. She has over 300 peer-reviewed publications, a research program focused on the intersection of informatics, health equity, nursing, standards development with over 30 years of NIH and AHRQ funding. At Columbia, she leads the Center for Community Engaged Health Informatics and Data Science, and she co-directs the Reducing Health Disparities Through Informatics pre- and postdoctoral training program. Her service notably includes currently serving as editor-in-chief of the Journal of the American Medical Informatics Association. She's a member of PCORI's Research Methodology Committee, and she co-leads the Engage Working Group of the NIH Novel and Exceptional Technologies and Research Advisory Committee. She's been recognized nationally and internationally for her contributions, including being elected a fellow of the American Academy of Nursing, the American College of Medical Informatics, and the National Academy of Medicine, and notably also awarded the Friends of the National Institute of Nursing Research Pathfinder Award, Sigma Theta Thal International Nursing Researcher Hall of Fame. AMIA has awarded her the Virginia K. Saba Award. And then in 2023, the Lifetime Achievement Award for Contributions in Informatics, the Morris F. Collin Award bestowed by the American College of Medical Informatics. As impressive as Sue's honors and her legacy of contributions overall as a researcher, really what I know her about, and something that's really, really notable about her, is her collaboration and her mentorship. She's paved the way for many trainees, myself included, in informatics, and she provides superb mentorship, career guidance, generosity of ideas, and collaboration. And with that, I'm pleased to welcome Dr. Suzanne Bakken for her talk entitled "Got Community: Reflections on the Relevance of Community Engagement in Equitable Health Informatics and Data Science Innovations."
Thank you so much for that introduction, Genevieve. It's my great pleasure to be here with you today to talk about this topic, which I'm very passionate about. And I'd like to just start out with a couple of definitions. And one of my first introductions into really thinking about learning health systems was this Institute of Medicine report that I served on in the early 2000s, and it was part of the patient safety series, one of the not as prominent as the report around to err as human, but we were really asked to think about patient safety from the perspective of underlying data standards and that kind of thing. And this was a diagram that we had in the consensus report. And I do want to just point out, I think we were thinking um, ahead of time. And we do see here that when we're talking about population-based analyses, that we are thinking about providers, patients, and communities. And I can tell you that many committee hours were focused on kind of getting this diagram right, but I think it holds up pretty well even 20 years later. But that was really fun to be part of. And one of the themes that I'll be talking about today is I tend to move between research and science policy. These are key interests of mine, and so I'll be talking about both how some of my research has influenced these reports, but also how they have influenced me. Earlier I can't remember, this has been less than a decade ago, I spent a year at the Institute of Medicine, and I was in a staff role as the nurse scholar in residence. And so I helped staff this particular report, which has been very influential on me. And it was called Communities in Action: Pathways to Health Equity. And as part of this, we came up with some definitions around what a community was. I can tell you, if you look back at the report, we actually had a number of case studies, including a few from Minneapolis, because of the good work that's happening in community engagement around health equity in your city. But broadly in this talk, thinking about community as both a social unit with commonalities in terms of religion, values, custom, or it may be also a geographical or a shared virtual space. And some of the key findings in this, and just themes that'll come up throughout this talk, is I'm arguing that community engagement is essential to advance health equity. Researchers cannot do it alone. And we know that failing to appropriately engage community can negatively influence the research process and its outcomes. And we're seeing a very interesting time in which NIH and other funding agencies are really thinking very deeply about community engagement as part of the research process. I'm going to reflect on the relevance of community engagement in health informatics and data science innovations through a particular lens, which is epistemic justice. And this is a framework I discovered in recent years, but it's been very helpful for me to think about what the things that I've done and also things that I plan to do. Just because we have a mixed audience today, I put up this slide, and I've been using the phrase health informatics and data science interventions. This is an example of a one person's view on thinking about data science versus machine learning versus health versus artificial intelligence versus informatics. So obviously they're all related. One of the things we think about is what are the data being processed, whether we're talking about numbers of data, text as data, images as data. And in this particular view, everything is fitting into artificial intelligence. If I was creating this diagram from the perspective of informatics, I would have more human in the loop, but we see a lot of attention these days to human-centered AI. So it's very important in really thinking about the different types of people that are involved, just not just as data sources, but how these things are being integrated into learning health systems. So I'm going to spend a few slides doing definitions, so bear with me. But epistemic injustice is a wrong done to someone specifically in their capacity as a knower. And this comes from a feminist philosopher named Miranda Fricker, who published this book about epistemic injustice in 2007. And she really talked about two different flavors of epistemic injustice. Testimonial injustice occurs when prejudice causes a hearer to give a deflated level of credibility to a speaker's word. And this could be at the individual level, or it also could represent a structural prejudice. Hermeneutical injustice occurs when a gap in collective interpretive resources puts someone at an unfair disadvantage when it comes to making sense of their social experiences. This may be due to lack of concepts to express one's experience or misalignment between one's experience and socially accepted concepts. And so thinking about testimonial injustice, and as I said, this occurs when a hearer gives a deflated level of credibility to a speaker's word. Could you raise your hand physically or electronically if you've ever experienced testimonial injustice in an encounter with the health system? And so I have my hand up, and I think anyone who's a parent probably has their hand up, because sometimes when we seek healthcare, and we may be, and we'd be saying, this is not normal for my child. So anyway, there are ways that we need to think about this. Hermeneutical injustice, as I said, occurs when a gap in collective interpretive resources puts someone at unfair disadvantage. And so I'd like to ask you once again to raise your hand physically or electronically if you've experienced a situation, a healthcare encounter, when there's a lack of common ground for communication. That is, it could be between a clinician and a patient, and you're just unable to communicate because you don't have the common concepts or things for that. Yeah. And so we see a lot of hands go up in that instance as well. The notion of epistemic injustice has come into the healthcare literature a few years after Fricker wrote her book. And there's been work in a number of different areas. One has just been sometimes thinking about the patient role, where being a patient in general puts you in a different type of power relationship where your experiences might not be valued. There's a lot of work in mental health and psychiatry, particularly around symptoms. Also a pretty big literature in terms of pain. And more recently, there's been some research and really talking about north-south collaborations or local versus generalizable knowledge. So this ends up being very important when we think about community engagement and whose knowledge is most important, and how we really navigate between the generalizable knowledge and local knowledge when we think about innovations and their design. So health informatics and data science innovation have the potential to perpetuate epistemic injustice. And a number of people who have been writing about this. One of the individuals that I find, whose writings I find most interesting, are Georgia Posey, and she really, she's actually a PhD student in philosophy at Delft in the Netherlands. So we can think about it from the perspective a number of different ways where this can cause some issues and perpetuate epistemic injustice. Thinking about it from the perspective of chatbots, and they may, as an individual's interacting with the chatbot, not all their symptoms or their experiences may be reflected in the responses. And so that can cause issues, of course, in communication and the resulting quality of care. Thinking about it from the perspective of generative AI, we all know that many of the big the open large language models, such as ChatGPT, are based on older data. And in general, one of the things we really think about in this area is whose voices are missing. And it can be missing just because of the age of the data, but it can be missing because a particular population is not represented in the data set for upon which the large language models are being trained. This plays out in predictive models as well. And thinking, once again, whose voice is missing, who's not in the model, which of these predictions are relevant to who. And another thing that Posey brings up in particular in some of her writing, and she uses the example of the US opioid abuse risk score, and brings up the problem of in a clinical encounter, a clinician having to think about the prediction versus the patient's experience, and what ends up being the gold standard, the patient-clinician interaction and the judgment that's made about risk in that, or what a predictive model says. And a similar types of issues can come up in terms of thinking about phenotyping and placing people into particular categories that influence the care that they receive. But just as these types of innovations can have the potential to perpetuate epistemic injustice, we also have strategies that are useful to mitigate epistemic injustice. And so thinking about some strategies that are very familiar to all of you, thinking about accounting for human-centered design of innovations, thinking about citizen science approach, integration of patient knowledge work into the ways of knowing, that is the evidence base for healthcare, and thinking also about technologies that promote access to data sources. And so very important technology in this area is the notion of open notes, which is becoming more predominant. Thinking about different types of technologies or process that are useful in increasing comprehension, analysis, and interpretation. And so one of the things that I'll spend more on this time, because it's the focus of much of my work, is the area of visualization and health communication. I'm going to go through a few projects quickly, just to kind of take these abstract concepts of epistemic injustice and think about a couple of my projects from this particular perspective. I really started in community engagement about 25 years ago, and I was at the University of California, San Francisco, and I was working with the Glide Health Clinic, which belongs to the Glide Church, which is a religious and social service organization for the homeless. And we got a very small grant from the National Library of Medicine to provide access to HIV resources. And one of the things we learned as part of this project, and it's kind of a big duh these days, but that the existing high quality resources were just at too high of health literacy level for the unstably housed that we were working with in the Glide Clinic. But when we put nursing informatics students there as health information navigators, people were able to learn and to, in fact, access the information. So we created a tailored site to be able to get that information out there. But what was very rewarding about this process is some participants actually were motivated to seek further training in the field of computer technology. And then we have at least one example in which someone's life was absolutely turned around in becoming a computer professional, starting with this particular program. Thinking about it in a much bigger context, in the era, the first round of clinical and translational science awards, we got the first opportunity for supplements was around thinking about ambulatory care research networks. And I led a project at Columbia, and one of the things we did was some community engaged research, talking to clinicians in the community, policy people, politicians in the community, community members. And one of the big things I took out of that research, small research project, was just that when we think about dissemination of science beyond the scientific dissemination in the literature, we really need to think about what are the messages for the clinicians, what are the messages for the patients, what are the messages for the community members. And so that lesson really inspired me in the context of a large grant that we had from ARC. That was the brainchild of, I think, one of Genevieve's, I can't remember if he's a classmate or where you were in relationship to each other at Columbia, but Adam Wilcox. And the basic idea was to take a variety of data sources and to put them into a research data warehouse, to build a research data explorer. Of course, these things are pretty typical these days, but they weren't typical at the time. My main contribution to the project was adding community members, because I felt it was very important that researchers would not improve the health of the community. They could contribute to the health of the community, but it was very important. We wanted that to happen to involve the community. So we knew in Wiser, because we gathered data from about 6,000 community members, most of the data collection in Spanish, that we had low health literacy almost universally. And so I felt if I wanted to give the data back to the community, I needed to be able to convey it through visual communication methods in a way that could be comprehended, acted on for self-management, and communication with healthcare providers by varying levels of health literacy. And it was also important that we do it in English and Spanish. And so we came up with, we used participatory design work with community members, doing about, I think, 21 sessions with maybe 102 participants, almost all of them in Spanish. And so we created infographics and also a tool to tailor them. And this would be an example of creating resources to mitigate hermeneutical injustice, because we're trying to provide common ground between the community members and the researchers. And then using that human-centered participatory design as a strategy for incorporating community members' lived experience was a strategy for facilitating testimonial justice, getting their voices into it. I'm just going to quickly show you some of the infographics that we came up with. This was a fatigue scale looking at overall health. This is the PROMIS anxiety measure. And you'll see throughout some of the infographics that we do, we use a number line with colors. Other cues that this has is, besides the colors and the numbers, really bolding out what an individual score is, and then also using the word descriptors, better, average, and worse. This is our body mass index. Once again, you see similar types of colors, and then also added some drawings to reflect the various body mass indexes. We also wanted to be able to compare different health measures that were on different scales, meaning different denominators in a single diagram. And so we found with this, which looks like a four-leaf clover or a flower, that when we went through many designs of this, but what enabled people to understand it was having the dotted lines across what a fully fleshed out flower would look like, and then also showing ideal. And this is because it's very hard for people to fill in blank spaces to look at proportions. When we did our participatory design sessions, we had the individuals had had each of the images on pretty nice cardstock in color. They could write on them. They could keep them if they wanted. This was the infographic that people took home most of the time because a lot of people knew someone that had hypertension. So in this, you see once again, we have the number lines, the colors, some of the same strategies you see. We've also added one of the ways the blood pressure gets taken. But importantly, we wanted to show also the risks of high blood pressure. And so you can see both the common word as well as the clinical word in this. And once again, in English and Spanish. This particular infographic has been used in a number of clinical studies, and it is actually in United Healthcare's glossary for patients as well. We needed to create some software to tailor each infographic to the individual person's results. So we created some software that we originally called Entice Electronic Tailored Infographics for Community Engagement, Education, and Empowerment. And so the basic idea behind the software is we had a set of graphical components, we had a style guide, and we had data. And so what Entice would do would create the tailored infographic. Over the next decade, we continued to just focus on a number of different areas, working on different types of methods for prototype design, for iterative participatory design, working on some automation. We did work in dementia caregiving, did work in a number of different areas. My collaborator and co-leader Adriana Arcia and I had always had the idea for trying to transform what we had done into a toolbox. And so we're in a few slides, I'll tell you particularly how we were able to do that. But with this work around returning research results to participants, this led to another policy opportunity for me to be on a consensus study that was focused on returning individual research results to participants. And although I had not really focused on returning biomarker results, we were returning more survey data. It was a very interesting process. And I was able to co-lead the chapter on advancing practices for returning individual results with someone whose name, a very famous person whose name I'm forgetting, from the University of Michigan. Anyway, it was quite interesting because on these committees, you're always figuring out how many recommendations and what you can do about it. And this information G, which I thought was a no-brainer, leveraging existing health information technologies to enable tailored, layered, and large-scale communication as appropriate. That kept getting edited out, and I kept putting it back in. And so I was very pleased. That was my one thing that I really wanted to make sure to get in the report. And paying attention to the editing, it did end up in that. The opportunity to turn what we had been doing into a toolbox really came from through the COVID epidemic, and NIH funded a series of studies through an initiative called the Rapid Acceleration of Diagnostics for underserved populations. And so we were able, through our project, to integrate epistemic justice-informed approaches to address disparities in COVID-19 testing and vaccination. While many of the projects, the majority of the projects were focused on getting people tested and getting them vaccinated, but our particular project was one of their social, ethical, and behavioral implications projects, which addressed issues around vaccination. So our idea for this project was reaching communities through the design of our information visualizations toolbox, or ReadyViz toolbox. And so the basic idea is we would gather information needs from the community, about vaccination and testing, and we would output tailored infographics on those particular topics. Although we envisioned this could be useful in many different contexts, because the focus of the COVID testing and vaccination rollout was very community-based in New York City, we decided to focus on community-based organizations. And so we're supposed to address ethical issue. Our basic ethical argument was super simple. We just said it's unethical to give people information that they don't understand and can't act upon. So we were really focused on using strategies that would support communication, inform decision-making, and motivate appropriate behaviors. And so this was a Columbia-led project in collaboration with organizations in the communities. A prime partner was the Association to Benefit Children, which participated both in the testing and in the vaccination arm of our study. We initially got the testing grant, and our focus was really African Americans and Latinos. There were two other health disparate groups in New York City, people, Bangladeshi, and also immigrant Chinese populations. And so in our vaccination project, we collaborated with NYU, which has a Center of Excellence in Asian Health, and worked with Project New Yorker, which is a Bangladeshi serving organization, and also with the Chinese American Planning Council. So we had 3 phases in our research. We collected data on surveys on almost 1,000 individuals in New York City and the populations mentioned through a common data element survey. A subset of individuals also participated in focus groups or interviews. This just shows who participated through the study and some of the demographics about them. The item I want to point out here, because it really informed the design of our infographics, was that 34% answered the numeracy question incorrectly. And you can see the question here: which of the following numbers represented the biggest risks of getting the disease? And it was not different by that percentage did not differ by population, and it did not differ by education level either. So 1/3 of the sample got that wrong. Motivators, I'm sure you're familiar with this from what the epidemic looked like in your situation as well. Trusted sources of information. We were pleased to see healthcare provider most trusted and social media the least trusted. And you can see where government and the US Coronavirus Task Force ended up falling out in that. Our focus groups, the interview findings did reinforce some aspects of what we discovered through our surveys, but it also highlighted some things that we didn't find out in the surveys. There was a lot of misunderstanding about how the vaccine works. People were concerned about the speed of development. While we expected going into it that we might see some cultural differences, actually, in some instances, it really was age that made a difference, with people who were younger, childbearing age, breastfeeding, etc., much more concerned about long-term effects for self and offspring. That was not the concern of the older population. We did see some instances in which it conflicted with some religious beliefs. There were 2 things that only came out in our Harlem work. One was around the notion of wait and see. People felt like they didn't see themselves in the data, and that data on average was not useful in helping them with their decision making. And I provide this quote related to the issue of prioritization of communities of color, race, fear of racist intentions. With this quote: "Are we the guinea pigs? White people usually get everything first." when I was disseminating findings to the Harlem community, I got a little, people reinforced that this was a belief, but I learned a little bit more about the context of it, and it was the fact that people in public housing might have just gotten a couple of masks, a little hand sanitizer, not very much in terms of some of the preventive supplies. And yet, when the vaccination came out, there were enough vaccines for everyone. And so that made them think that perhaps they were the guinea pigs, and that once the vaccine was tested with them, the white people would get the real vaccine. But from this community engagement, we learned a number of things which informed our infographic design, that the content needed to address the different types of tests, vaccine mechanisms, and platforms, that we really needed to be able to take into account the key hesitancy concerns of specific problems: childbearing age, breastfeeding mothers, Black elders, and other design considerations. It was really important because the community-based organizations were so trusted that we needed to allow branding from a trusted source in the community. It was important to support cultural congruence. And we really needed to think about the options for communicating risks and proportions. As we moved on to the participatory design phase, in general, we use two different phases. One is broad and shallow, and that is we do some design surveys, usually with a couple hundred people, where we try out different icons that helps us winnow down and choose the ones that are most likely to work. And then we go into the deeper participatory design with groups of individuals and sometimes individual interviews. And early on, we needed to make a decision about which approach to use. And so we workshopped a couple of approaches, whether or not we were going to go with the textbook approach or personified approach. I was personally concerned, if we did personified, that people might think it was more childish or perhaps not as serious, but it was very clear in early reactions that personified was the way to go. So that's what we went with. I'm showing you our final vaccination infographic, and this uses a conceptual metaphor of war, vaccination, so thinking about vaccination as being a fight against the virus. So you can see it has a set of characters. The characters have weapons. You can see the notion of like a lightsaber that's helping to fight off the virus. And so the idea from this is that this is a set of standard information that everyone gets, and then through our visualization toolbox, these additional modules can be added to the infographic. We have developed the software to tailor the infographics. Initially we were calling it the Ready Visualization Toolbox, but there is some software called the Ready Visualization Toolkit, which has nothing, doesn't do anything. It's a completely different product, but we felt it was too close of a design, a name, and so we changed our name to the Tailor Viz Toolbox. So this is a pretty simple web-based tool. There is a catalog of infographics, and a community-based organization can select the infographic they want to work with in English, Spanish, Bangla, or simplified Chinese. They can edit the text, they can brand it with their logo, they can update the pictures to more carefully reflect the clients that they're serving in their organization. So it was important to us when we were developing this that we make sure that we had approaches that were scalable and extensible. And so in the first project that we're extending it in, is a project called Ignite for the All of Us program. And in this particular program, what the Ignite project does is it really introduces community members, clinicians, etc., to the All of Us research program. And it does it through a set of training, and some of the trainings are at the level of the public browser rather than the more controlled browser, which gives you access to genomic data, detailed clinical data, etc. But the parts of the Ignite program is they engage these different groups in data picnics, data sandboxes, or it could be a data playground, which you would use the controlled access. So currently, one of the strategies in the data sandbox experiences is people do a set of activities. One of them is like a treasure hunt, in which they use the Public Data Explorer to answer different types of questions. And so how we're integrating the Taylor Viz toolbox is after they do the treasure hunt on a particular topic, they will be able to create to use our Taylor Viz software to create an infographic that they can use for their community-based organization, and they'll get the other infographics that are in the toolbox. And so how we think about that is as a strategy to mitigate hermeneutical injustice, because we are providing a tool that's going to help community-based organizations create and tailor an infographic that will work for their community. And as I said, now we have it available in just the 4 languages, but there's potential to do different types of infographics. The first one that we're doing for All of Us is going to be focused on pre-diabetes as a strategy for prevention of transitioning to diabetes type 2. I want to mention a current, now back to the policy level. One of the things that Genevieve mentioned in my introduction is I am co-leading an effort at the NIH called Engage. And this is focused on enhancing public engagement in clinical research. And so our particular work group is charged with creating a framework and a toolbox that will facilitate public engagement throughout the phases of the research project. One of the things that's really important to it is spearheaded and under the auspices of the NIH Director's Novel and Exceptional Technology and Research Advisory Committee, and links to the advisory committee to the director as well. And what's important about this for an audience that includes informaticians and data scientists is we're not just thinking about traditional research, we're thinking about what level of public engagement is right when you're doing something like creating a phenotype, you're creating a predictive model, maybe you're doing work around generative AI, or so really thinking about different types of use cases, including integration of a variety of novel data sources that might lead to discovering something about an individual that they may not know, or they may have chosen not to share. So I think there's some very interesting work going on. I will send Stephanie a link within a week. We will be releasing some requests for information on this particular project. And we also will be doing community conversations face-to-face around the country. So I just wanted to let you know that this was going on, and we'll provide you with an opportunity to respond to the requests for information. We will not only have the written opportunity, but we will be hosting a webinar in April to give people a little more information about this and the opportunity to start to gather public engagement in our process about public engagement in the research process. So in conclusion, I really wanted to just share my thoughts around the role of community engagement in health informatics and data science innovations, and particularly looking at it through the lens of epistemic justice. And this really suggests the need. It's important that we broaden the diversity of input, lived experience in the implementation of the creation and implementation of data sets, algorithms, and innovations. It's also important that we continue to develop strategies and tools that facilitate community determination of prioritization and health-related resources to meet those needs. Help with community capacity for co-production, translation, and dissemination of data, information, and knowledge. And then lastly, that we really work on applying or developing science policy frameworks that help to support epistemic justice. And with that, I just acknowledge my research funding collaborators and our cultural experts that work with us on this program of research. So with that, I think we're going to turn it over to Stephanie for questions and comments. And I thank you very much for your time and your attention.
Yes, thank you, Dr. Bakken. That was fantastic. We have about 7 minutes or so for questions and answers. So if you have questions, feel free to post them in the Q&A or raise your hand and I will unmute you. Yes, so put your questions in the Q&A or raise your hand.
Maybe I'll start us off. So Sue, thanks very much for your seminar presentation. I'm curious what suggestions you would have for somebody that maybe is at the beginning of doing work in this area. Because it's a vast field, and I think where to start and where to focus, and just practical advice that you might have.
And what do you mean by in this area?
So how to incorporate community participation in a research question. So
I hear what you're saying now. And one of the big challenges, and that's what our NIH committee is trying to address, is that every researcher almost starts from scratch, and that there aren't existing tools that can make this easy, like even IRB protocols, methods for different types of methods for engaging, and knowing like how much engagement at which point is going to get you kind of the bang for the buck in terms of where you're going to get the most value in your particular research question. And so I think it's really important that people have this in mind when you are, I think more and more people will be asking to build it into the research protocol. So they will be, that's one of the big issues, is agencies want it, but they won't pay for it. And we're really hoping our work at the NIH will change that. So people need to be able to take advantage of their existing resources, such as if there's the community engagement resource at the CTSA level that can help with some of those kinds of things, existing community relationships. Some people have standing community advisory boards that can be engaged, because it's very difficult if you don't have some basics to really get started. But I think we absolutely and in addition, I think we just need to really reflect in our projects and really be thinking about in in their limitations, to really be reflecting on just being clear and acknowledging that some voices may be missing in this particular project, and we need to have strategies that thinking about strategies that can advance the inclusion. One of the things that I've done systematically, and you mentioned, Genevieve, that I was the editor-in-chief of the Journal of the American Medical Informatics Association, and we just had our 30th birthday. And one of the things that the editors before me and I decided to add a goal for the journal, and that was explicitly to among promoting diversity, equity, inclusion, non-stigmatizing language, but really also paying attention to things such as epistemic injustice, and looking at the papers from the perspective of really thinking about, is this a project that should have that lacked public engagement, where it would have been useful to advance the science as well. And so we know we're absolutely not there in expectations from the funders, and in the practical support to support researchers to do this, and that's why we need to work at the policy level as well as through research examples to really change the paradigm and say, and I keep saying in this committee, I keep reminding people, we're not talking about participants in trials, and of course that's important, but just the feeling that and many people would say, well, why would you do engagement if you're using existing data sources? But it really is important to know that you're addressing the right questions, and you are really understanding the situation that people are going to be put into, in both not only individuals directly receiving the algorithmic output, but clinicians being in settings and needing to discuss these things with patients. And so having really understanding that kind of situation early on, and a lot of more input ahead of time, can, I think, make that experience more meaningful or more useful. I'm sorry, that was kind of a long answer. Just to say, Stephanie, do we have any other questions?
At the moment, we do not have any other questions. So that was a great, thorough answer.
Okay.
And you can feel free to put one more question in the Q&A or raise your hand. I will wait a couple seconds for that. In the meantime, I would like to remind everyone that our next seminar is on May 7th at noon Central Time. And I am not seeing any questions. So once again, thank you very much, Dr. Bakken. And this concludes our presentation. Thank you. Bye.
Thank you, everyone. It was my great pleasure to share my thoughts with you today in your seminar. I appreciate the invitation. Bye-bye.